my great pleasure to introduce Teresa O'Leary. I knew Teresa, I've known her for over a decade now. We met on a project in the emergency medicine department many years ago. And since then, she's gone on to get her PhD in what is it in? It's not in informatics, is it?
It's personal health informatics. Yeah.
There we go. There we go. And has come back. So she went to Boston, to Northeastern, but she's come back to Yale, and we are delighted to have her back in the institution. And with that, I'm going to turn it over to you, Teresa. You might want to tell, let us know if you want to be interrupted or.
I do.
All right, well then, we've got free reign to interrupt Teresa.
Yep. So I'm more, especially because it's a small group. So feel free to interrupt and ask questions. I'm gonna try, I think this is like a 25-minute presentation because I specifically just want to be able to have a conversation.
Oh, good.
More than just talking at everybody. So this work is a part of a larger project, which I'll go into, but it is my dissertation work. I think I defended it in November, and then I immediately came over to Yale. So this is, the project that I worked most on during my degree. Okay, so again, it's this co-design and evaluation of a smartphone-based mental health promotion and anti-stigma embodied conversational agent for church-affiliated Black adults. So today we'll cover the motivation. We won't actually cover my related work because you guys don't need it. We'll go over some of the formative work that led to the design of the system design, which I actually will go into with some depth, which is nice. I hate it when people, talk about interventions, but you don't get to really see what it's about. Then I'll go over like the pilot evaluation that I did at the end, some final conclusions and thoughts. And if I have time, I'll tell you a little bit about my research interests going forward for collaboration purposes and just so people get to know me a little bit better. So as of 2018, the National Alliance of Mental Illness estimates that about 19% of Black and African American people are living with a mental health condition. And despite the availability of effective mental health treatments, of those African Americans diagnosed with a mental health condition, 1/3 are engaged in formal mental health care, whereas white Americans with similar rates of mental illness have higher rates of formal treatment utilization. Research has also shown that when it comes to matters of health, many Black and African Americans rely on their church's social network and institutional connections. And this makes sense, right? Because churches have access to health-enhancing affordances, like community meeting spaces, a network of social support, and connections to local community-based resources. Predominantly Black churches have historically been instrumental in addressing racial and ethnic health disparities, acting as the site for health promotion events, a place for church members to give and receive social support, and then a bridge to healthcare services. And while health promotion programs anchored in predominantly Black church communities have definitely demonstrated success, they also face numerous constraints. So they rely on physical access to the church and its programming. They're limited by the church's capacity, and few of these efforts have addressed mental health, in part due to stigma within the community. So to address this gap, I designed, developed, and evaluated a faith-based mental health promotion intervention featuring this embodied conversational agent on a smartphone. Now, embodied conversational agents are these animated characters, and they simulate face-to-face communication using speech and nonverbal behaviors to interact with their end users. In my system, to interact with the agent application, you'll hear agent utterances synthesized using a text-to-speech program. And then to respond to the agent, you select from one of the menu options that populates during the conversation. So research has also demonstrated that ECAs can effectively deliver health promotion interventions using counseling techniques. They can develop therapeutic working alliances with their users, presenting a somewhat straightforward translation from in-person counseling to a digital intervention. The primary aim of this particular project was to increase the care-seeking intentions of church members experiencing depression while simultaneously activating lay church members as sources of mental health support by reducing mental health stigma within the community. and creating compassionate responders, essentially. Okay, so we'll be skipping the related work and going to my formative work. So my dissertation work was part of a much, much larger 4-year community engaged research project called Smart and Connected Churches. And the project focused on reducing health disparities in predominantly Black church communities in the greater Boston area. And specifically, the goal of this project was to design, develop, and evaluate an mHealth application to assist church members in solving problems that they identified as important as a community. And so as part of the team, I ended up conducting the formative work, which I definitely have presented here in certain amounts of depth. And I worked with 2 different church communities during my time there. We ended up doing 10 participatory designed focus groups, each activity building upon what we learned in the previous activities. And this work helped facilitate participant design contributions that reflected their community's goals, their priorities, and their cultural values. The formative work ended up culminating in 2 field studies, and the acronyms CHI and IBA that you're seeing here on the slide represent the computer science venues where this dissertation research is now published. And so today I'll be sharing a subset of this work. So first, I facilitated a health priorities affinity diagramming focus group where members identified their most pressing health concerns for both themselves and their communities. Church members ended up identifying from both churches that mental health was one of their highest health priorities. And when I asked participants to then re-rank their health priorities from most addressable to least addressable, mental health ended up plummeting from the very tops of their list all the way to the bottom. And when I asked why, participants shared that they just didn't believe that their churches could adequately address mental illness because of the prevalence of stigma within their churches. And it's this finding that then catalyzed my exploration of this space. So then I facilitated an agent design dialogue tailoring and validation study. This work was critical. It demonstrated in very, very practical ways participant expectations for creating agents that felt relevant, genuine, and appropriate to their communities. In the agent design session, participants ended up brainstorming and creating 33 unique agent designs, each with their own role and persona. And then the subsequent dialogue tailoring focus groups, participants tailored a health counseling conversation using language related to their faith and culture. And so this work established a set of ECA design guidelines for creating community-based, culturally informed ECAs. And then I conducted a 30-day field trial evaluating the Church Connect app. At the center of Church Connect was Clara, an embodied conversational agent designed as this peer health advisor. And at this stage, Church Connect included a suite of features promoting physical, spiritual, and social well-being, but not yet mental health. So 25 church members from churches A and B ended up using the app, and the results of this study demonstrated that it was feasible and acceptable to deliver health interventions using the ECA on a smartphone with church members. And then I built my mental health promotion intervention on top of Church Connect's existing system architecture. So my next step at this point was to interview church leaders to identify requirements for the mental health intervention. And 8 church leaders from churches A and B reviewed a scenario-based storyboard and then provided feedback. The storyboard followed this fictional character named Jasmine on her user journey. It starts out with this kind of opening scenario. Jasmine is struggling with depression. The storyboard depicts her as unsure as to who to talk to, and she's not yet ready to begin formal treatment. She's feeling very, very isolated. And as part of her journey, Jasmine remembers her church has this app with health resources. So she launches the app and she starts to investigate how the agent could help her with her mental wellness in this kind of non-threatening environment. And the next part of the storyboard then contains 8 screens with 8 features facilitated by the agent. And that's what the screens kind of look like, as you can see on the right. So these features included that I was testing in the storyboard: psychoeducation, a mid-conversation check-in, screening, resource referrals, CBT exercises, self-care activities, role-playing, and the inclusion of scriptural content. So on the right, you can see 2 features as they were presented to the participants. One is this mid-conversation check-in, where the agent asked Jasmine how she was feeling, given the seriousness of the topic. And the second is the psychoeducation example, where the agent begins to broach this topic of mental health myths with Jasmine. So interviewees were asked to review all the features and provide feedback and then rank the features for me. So these are the findings from that workshop. So even though leaders acknowledged that, yes, church members have approached them about mental health challenges, they also shared that there just currently was no consistent mechanism in place for adequately or sensitively responding to member mental health challenges. And I remember one pastor said to me, like, it really depends on who you talk to at the time, what kind of response you're going to get. All interviewees agreed that an automated church-based app could offer credible and consistent resources. And then leaders shared an app, especially one from the church, could help normalize depression by passively demonstrating the church's support for the topic. And then they finally ranked the features. The top features were psychoeducation, scriptural content woven throughout the health counseling content, actionable support strategies, and resource lists presented by the agent. So in summary, for the formative work, the Health Priorities Focus Group established mental health as this priority for the churches. The Agent Design Focus Group established what the ECA design guidelines for developing a community-based agent. The pilot study demonstrated feasibility of delivering the health intervention to members using this ECA on a smartphone. And then finally, the mental health feature identification workshop identified the most desirable and pressing system requirements for the mental health promotion intervention. So now I want to talk a little bit about the intervention design. All right, so the digital mental health intervention featured Clara. This is the updated Clara, designed as a peer mental health advisor. She leverages person-centered therapeutic approaches to communicate with her users, and her persona is that of a person of faith. She's there to share information, to educate, encourage, and support her users. And the mental health intervention prioritized two groups of primary stakeholders, individuals with depression and then other community members. And while these two interventions, they definitely shared significant elements, they also had very unique elements and were tailored differently. So I created these two mental health promotion interventions for two reasons. First, our social connections, as we all know, heavily influence our health, and they facilitate or they discourage our individual care seeking. And then secondly, concealing a mental illness from one's social connections can also reinforce stigma and feelings of shame. So for the first stakeholder, the individual experiencing depression, the goal of the intervention was to reduce self-stigma and promote care-seeking intentions. And then for the community members, the goal was to reduce public stigma and increase confidence in discussing and engaging with topics of mental wellness with others in the community. So during the first interaction with Clara, she introduces herself, she welcomes the user, and then she introduces the topic of mental wellness. And then she handles the stakeholder assignment by asking users two symptom-related questions and their primary motivation for using the application. Every subsequent interaction after that is tailored by stakeholder assignment. At the start of an ally session, for instance, so community member, Clara greets the user, she engages in a few turns of social chat, and then she asks, so what would you like to talk about today? And presents this intervention content in a menu set. The intervention includes 5 main mental wellness topics, each lasting about 8 to 12 minutes. These topics include the psychoeducation, a screener, social stigma education, a myths and facts quiz, and a session focused on activating allies as compassionate responders.
Teresa?
Yeah.
Sorry, I wanted to interrupt to say, to ask you if you could tell us, I don't think I heard it, a little bit about, more about how you recruited and who qualified to participate in the research.
Yeah.
I
Okay.
did, since there seems to be two groups also, I wanted to.
Yeah, absolutely. So that'll get to that, the study design, for sure.
Okay.
But this was a small pilot with depth of data collection. So I ended up recruiting 12 people, 6 from each church. I also stratified 6 users screened as depressed and 6 did not at the time of study inclusion because I wanted this even group. The 6 people from each also knew each other because they're from the same church community. And yeah, those are the specifics. They weren't the key informants who were involved in the first part of the work that, that first year where I was doing all that formative work. We had a group of 15 key informants. So for the affinity diagramming session and the agent design session and the mental health feature workshop, those were all different people that ended up not being the evaluation group. But yes, so 12 folks, 2 different churches for this particular study.
Thanks.
Yep, of course. Okay, so then they see these 5 mental wellness topics and they get to choose whatever they want to choose in whatever order they'd like. I wanted to make sure that the curriculum was very, very flexible, and so people could just choose what was either most exciting or what they felt would be most valuable for their time. They also had access to a persistent set of FAQs and resources that were also tiny, tiny micro conversations with the agent. And then once the core intervention curriculum was done, and all the purple stuff is what the core curriculum is, they would then have this graduation session, which was just like a set of final thoughts and strategies for them to consider as they move forward. And then for the individuals experiencing depression, their session starts super similarly. They get the social chat, but they also get a symptom check-in. And there's a conversation that's about care seeking. They also get a care seeking check-in. I'll explain a little bit more of that in a second. But unlike allies, the users with depression had 6 core sessions, including a self-disclosure planning session and a care seeking encouragement session. The care seeking encouragement session also ended up having homeworks to try to get them to do activities that could help promote care seeking. So the intervention also included 2 different content areas. There was the depression and stigma. And the depression intervention included a session focused on psychoeducation, where Clara educated users on depression prevalence and symptoms. The screening session, which was the PHQ-8 baseline screener that Clara would deliver in conversation. They also had resources, which included a number of faith-based and secular resources. And when asked, Clara could text these resources directly to the user's phone so that they wouldn't have to go back into the app and find the resources. Clara also shared self-management strategies like journaling, meditation, physical activity, leveraging one's church or religion for support, and relaxation techniques. And the intervention contained this encouraged care seeking session. The session provided this overview of formal mental health treatments, culturally responsive encouragement and problem solving, and then a next step homework activity designed to encourage care seeking. Community allies had companion content. Their content included the same overview of formal treatment, and it covered how to respond and support the care seeking intentions of others. All right, so now this was the stigma reduction approach that we ended up taking. So based on the literature, I used an approach that was this mix of education, something called para-contacts, and self-disclosure planning. Now, a para-contact it's like in stigma research, you'll have a contact with it, which is, maybe you'll attend a program and somebody gets up on stage and they talk about their experience with mental health and recovery. That's a contact. And there's lots of different stigma reduction interventions with contact-based interventions. For this, we're doing a para-contact. It just means an asynchronous story that's delivered to the person in different types of ways. And in this instance, they were stories that there was a video, and then some of the stories were just written accounts, but they were sprinkled throughout the different education sessions. For the social stigma education, it starts out with this overview of stigma. It defines self-stigma, discusses stigma in religious communities, and then it includes those first-person accounts, those para-contacts. And users could explore these accounts and reflect on the testimonials in conversation with Clara. So I also included this interactive myths and facts quiz. The quiz was 11 questions long and positioned as an educational tool. Clara would ask each user the question, the users can respond, and then depending on their response, she offers her own perspective and feedback. It was not a you lose or are getting graded type of thing. It was purely for education. And then finally, the intervention included an introduction to self-disclosure planning. So in this session, Clara educates the users on the benefits and also the drawbacks of self-disclosure and provides tips on what to consider before disclosing to anybody. This approach was to minimize harm through careful planning, given the level of stigma within the community. And then finally, the stigma intervention for both stakeholders included a set of actionable, practical strategies for reducing stigma in the church. And they were framed as the big and small ways of creating a more loving and supportive community. So then this is about the evaluation. So this evaluation was a quasi-experimental 2-week field deployment where participants ended up using the app every day and were interviewed about their experiences. So I recruited 12 adults from historically Black churches in Boston. And then during the initial study session, participants completed pre-study measures and a semi-structured interview with me. They then installed the application on their phone and completed their first interaction with the character in my office. And then between study sessions, participants were asked to use the application for about 2 weeks and reflect on their experience using a diary. So they had this journal that they took home and would write about their experiences. And then 2 weeks later, participants engaged with me in another semi-structured interview. And we're going to move right to the findings then. So the pre-intervention and post-intervention interviews totaled about 13 hours of recorded data. I used a rapid qualitative analysis approach and identified 4 themes in the work, which I'll present. Like I said, I enrolled 6 church members experiencing depression and 6 who were not. All participants self-identified as African American, and all participants were also women. 11 of 12 participants completed all sessions with Clara during the study period. And they rated the experience with the app and the agent on several single item measures. All of these were significantly greater than neutral. Specifically, participants were satisfied and willing to continue using the app. They were willing to recommend the app to others. They found it super easy to use. And they were satisfied with the character and willing to work with her. They also trusted and they liked her. So in the interviews, participants, they described Clara as this partner. They recognized her as a peer who provided informational and emotional support to them, shared their beliefs, respected their autonomy. And they described her as a guide, a calming spirit, a church lady, and friend. And when it came to her persona, they stated she was compassionate, she was non-judgmental, and non-threatening. And these feelings were often attributed to notions of choice and mutual respect throughout the conversations. So I asked participants to compare the use of Clara to other modalities like text on a screen, a video, or a chatbot. And in response, participants shared their experiences and perspectives on how Clara's embodiment added value to their experience, stating that the embodiment promoted an ease of use and signaled community membership. And participants also recognized that Clara was tailored and believed that she was appropriate for their communities. Clara's embodied self also normalized discussing mental health and illness with a person. So here we have one participant who stated, Clara gets people closer to a human connection. You have more feelings when it's a person's face than when you're just reading information. And several participants confirmed this finding, stating that talking about mental wellness with Clara helped them imagine discussing this content with other people then. And so in combination, the ratings and the interviews, I found that overall participants were highly satisfied with the agent and the experience. And so this brings us to theme 2, intervention approaches for engaging church members with depression. So the intervention supported users with depression in the following 3 ways. It supported self-reevaluation through the screener and symptom check-ins. It introduced the idea of self-disclosure planning, and it provided a non-threatening intervention entry point, which I'll go over. So when it came to the self-evaluation, participants explained that the symptom check-in, as is, helped them identify symptoms of concern and explore self-management strategies. And then 3 out of the 12 participants took this a step further and imagined Clara as Clara's wellness check, essentially, where Clara would suggest brief interventions based on how the users respond during the symptom check. And then all participants welcomed the disclosure planning session. So now participants' reactions to Clara's neutral stance on disclosure varied. Some endorsed her stance, stating that it promoted autonomy and reminded them to exercise caution. Others believed Clara's stance should be more prescriptive, adapting to how much distress concealing one's mental health status is causing them, which I thought was a pretty interesting point. Participants from both stakeholder groups provided positive feedback on the intervention's framing, stating that it created this non-threatening intervention point for hesitant users who might not be ready or are unaware or in denial about their own mental health challenges. So those hesitant users were able to sign up as community allies. And indeed, I ended up having 3 community allies who went into the intervention with the primary aim of supporting others, but then learned skills that they then leveraged for themselves when it comes to their own mental wellness. So interviews also captured some detailed narratives about how participants were starting to consider stigma. So in this theme, participants described shifts in attitudes towards mental illness that then results in new actions that they took during the 2-week study period. So these shifts in attitudes ended up happening for 9 out of 12 church members, and they were organized into 3 different categories: changes in how the individual planned to respond to members with mental illness, changes to their sense of confidence when helping others, and then a greater sense of self-awareness. So when it comes to changing how they respond to others, participants mentioned things like they were going to be a better listener, being more aware of what others might be going through, and ending their use of stigmatizing language. For instance, one participant shared, "I can use it, the app, to change the language in which other people speak as well as myself." And then 3 of the 12 church members experienced changes in their sense of confidence when it came to helping others. So one participant said, "There's an awkwardness. If somebody is physically sick, you're like, 'Oh, how are you doing?' But mentally, if mental health is an issue for the individual, how do you approach them? Clara gave me 2 simple questions you can ask." And the intervention also helped facilitate a certain amount of self-discovery and self-awareness. There were several cases of participants becoming more fully aware of symptoms that they were experiencing. So in recent months, one participant had told me about how she lost her spouse and reported having not properly grieved his absence from her life. She said, "So I check on myself in listening to Clara and say, is that me? And I know one thing that can impact me is my being too tired. The app puts that on your mind. The app could help me stay ahead of it." And so as participants start to consider stigma, we see these shifts in attitudes, and then we see a series of actions that they take. I broadly organize these actions into 3 types: so sharing information, discussing mental wellness with others, and care seeking. So when it came to actions, 4 of the 12 participants described instances where they shared information and resources directly from the application with both church members and their broader social network. And this practice helped participants start a conversation with those that they were worried about. Participants described how using the app led to discussions about mental health and illness with others. For example, P4 shared the application with her husband. They were often interacting with Clara and the content together. And then P3 attended a family dinner and showed the app to others. She stated that prior to the intervention, she hadn't discussed mental wellness with her family in a casual setting before. So it was their first time. And then 5 out of 12 participants shared how the application facilitated their care seeking. Post-intervention, one participant recommitted to finding a mental health provider, crediting Clara's advice and reminders. Another participant contemplated if she might benefit from speaking with a counselor postpartum and used the app to research providers. 2 participants attended appointments during the study period where they leveraged content Clara shared within the application to advocate for specialty treatment. One used it to address a medication change, and another asked to be referred to a counselor. And then a 3rd participant described an emotionally charged experience she ended up having with her PCP when she asked for a memory exam due to concerns that were prompted by Clara's depression screener. And this participant ended up saying, "You have professional help, but they're not hearing you. I shared with her about my forgetfulness with my PCP, and she said, 'Your labs look good. I'm not worried.' And I said, 'You're not, but I am.'" So P4, when she told me this story, she talked about the new sense of confidence she had and the empowerment that she felt, and that she felt like she could sort of push during the appointment in a way that she hadn't before. And luckily, her provider was open to that. So sometimes with patient activation, it's worrying in that providers maybe aren't open to patients actually advocating for themselves in these situations, or they're not used to it. This provider ended up doing the memory exam, and then she ended up getting the care that she was really looking for. All right, so participants ended up crediting the stigma reduction and care-seeking intervention with supporting their care-seeking behaviors and intentions. And this is my last theme for today. It's called Feeding the Flock, Community Approaches for Mental Health Promotion Within the Church. So all participants noted that while they found the intervention helpful in changing their intentions and their attitudes, they desired an intervention that could affect change, like stigma reduction on the congregational level. And the only path that they believed that could accomplish this was the creation of synergistic community-sponsored programming to complement the application. They brainstormed a bunch of ideas. These are just some of them, but they thought about like a panel discussion where volunteer church members could share their experiences with mental illness and stigma, small discussion groups to kick off app use and support continued engagement. They talked about sermons that would be focused on mental illness to signal leadership involvement and support. And then a mental wellness committee they were also super interested in that could provide resources and support to interested members. They imagine that using some of these in-person approaches in concert with the app could increase intervention awareness, adoption, and engagement. But then they also wanted to see community reflected within the application itself. They wanted to see features that facilitate the exchange of social support, reflect community assets, and signal community progress toward a culture of support. So they prioritized and brainstormed community features that emphasize taking action together as a collective group. And then some of these ideas included things like sharing church member testimonials in apps. So they loved the para contacts. I would say it was one of their most favorite parts of the app, but then they wanted to take it a step further. And they wanted para contacts that were church members, friends, family, folks in the church who have had this experience. They wanted to see listed resources offered by the church and also display numerical representations of application usage. All right, so we're going to conclude. So the 14-day field deployment evaluated an ECA-facilitated mental health and stigma reduction intervention among 12 church members from 2 communities. And this study adds to the limited literature focused on evaluating mental health promotion initiatives in predominantly African-American church communities. And it's the first of its kind to deploy a digital mental health application in this setting. So I found that church members were highly satisfied with the ECA. Digital mental health interventions that explicitly address stigma can prime care-seeking behaviors. They can change participant attitudes and activate community members as sources of support. The self-disclosure planning introduction was considered a valuable addition to the mental health promotion curriculum. And the ECA-based interventions that incorporating stigma reduction strategies can help build users' confidence in discussing mental wellness topics with others, which was what I was most interested in, to see if this could facilitate sort of group conversations about this topic. And then I also learned that using this 2-stakeholder approach was interesting. It helped some users access intervention content without ever having to self-identify as needing help. And that such an approach may help provide care earlier to individuals who might not otherwise recognize that they too could benefit from additional support in this area. All right, so that's it for the study. I'm gonna move this for a sec because I'd love if anybody has questions about this or wants to know more, I can go into it now.
Hi, Teresa. Oh, sorry.
No, that's fine.
Oh, okay. Good afternoon, Tamara Taggart. I'm at George Washington University. I was a postdoc at CIRA previously. This is an excellent project and presentation. Thank you so much. I got a whole book full of notes and very excited. I have a lot of questions. I'm going to try to just focus on 2, one sort of a smaller kind of question and another more kind of conceptual. For the smaller question, I was curious if you could talk about what prompted you to select an app versus kind of a web delivered type of intervention. So was it because the parent had that sort of already set up, or kind of what was your decision making around using an app versus maybe online or web delivered type of intervention mechanism?
Yeah, that's a great question. You know, to be fully honest, the way the grant was written was we were going to make a smartphone-based app. But I will say, the reasoning for that, they wanted people to be able to access intervention content beyond just using a computer, right? They wanted to be able to leverage a logs analysis. You can get more information from an app that's installed on people's phone. And you can have a greater degree of interactivity with the app, because you can leverage like the sensors on the phone and things on the phone to understand the physical activity people are getting, things of that nature. We were also interested in location-based. I didn't include any of this in this presentation because it's not a part of my intervention, but part of the system architecture, they also have like context-based messaging, which is like I think because you're shaking your head, but like a just-in-time interaction that's happening for participants for physical activity and I think the nutrition intervention. So it's partly that they wanted to leverage that. They also leveraged messaging features as well. And I think all of that is just more robust than a web-based, thing, though it is more accessible web-based. And I will say that, in a different presentation at some point, there were a lot of issues at the end in terms of, considering how to make the intervention reach the most amount of people in the broadest way, to include the highest number of folks, but then also delivering something that has, some of these innovative components. And I will say what I learned from it in particular are things like the agent, while embodiment was interesting and great and interactive for some people and engaging, it also takes up a ton of space on somebody's phone. And so if I were to do this again, I would have had like a chatbot version of Clara just to make it easier to process on somebody's phone. So there was like a lot of issues, and I love where you're thinking.
That was actually my follow-up question was around doing the Clara versus kind of a chatbot. Lauretta, do I have time for one more question? I don't want to.
Absolutely. Take
Yeah,
it.
go for it.
So 2 more questions. So thank you for answering, because that was my next question, was about whether or not you all had explored a chatbot or not. So my second question was more related back to the content. So I was curious around, so it's interesting to see some of the content that you showed from the intervention. It wasn't necessarily explicitly religious or spirituality focused or what have you. Like it was parts of it were there, and certainly the themes that you showed and shared from the interviews that came up. But I was curious if you could talk about what sort of decision making you all made around what religious elements to include or not include. And then I'll just, yeah.
Okay, that was all driven by the participants and the pastors. So all of the content that I wrote, and all of it I could never share here, but all of the content I wrote after I wrote it and took a stab at how I think things should be, the pastors and also other key informants ended up going through line by line and editing or adapting or asking for changes. And so it was interesting because we had users who were like, I want more spiritual content, right? And then we had users who were like, whoa, you don't need to have like the churchiest of church ladies talk to me, and it was really, so for me, for work going forward, whenever you're creating techno-spiritual stuff, I think it's highly important to actually figure out a way to deliver content that's more tailored to the expectations people have around how religiosity and faith should be interwoven in content. So there was interwoven content. There was also other features like Bible story of the day that's outside of this, but it's certainly a part of the application. There are Christian-based meditations that I spent time writing with participants. And then there was also a prayer wall where they could give and receive and exchange prayer support within the application. And I also ended every single session for the mental health with a scripture. So they could skip that part. They could say like, no, I'm good. We're fine. Or Clara could she bows her head and she ends in scripture, mostly because the ways in which the participants talked about ending their groups a lot of the time, they wanted it to feel like the way they end groups when they're in small groups at church and how they end fellowship. So that stuff was there. And that's more of the spiritually stuff. But I still think there's so much room and opportunity for actually figuring out ways to tailor spiritual content. dynamically using these systems. And I think it can be as easy as literally asking for feedback from the user and then sort of tailoring into tracks. I don't think it has to be the most fancy algorithm, but I think it's important because we definitely had people who, I think my interviews were split where it was like, I wanted more and then I wanted less. So yeah, thank you for that question.
Teresa,
Thank you.
did you have another question, Tamara, before I blurt out mine?
Well, this one's super minor. I just, at the end, maybe 2, 3 slides ago, you started, some of the themes you talked about started to get into kind of the church space and the organization and people kind of desiring to see some changes around stigma, around mental health, with kind of the faith-based organization, a larger community of faith. And I was just curious if, what you all are doing to kind of respond to that more, or in the next iteration, how you all are kind of responding to participants' comments related to what sounds like kind of shifting the space a bit. And then that's my final question. Sorry.
Well, that's a great question. So unfortunately, right now, this is in like clinical trial, it's in an RCT. So I can do nothing. However, I think in the future, in my future work and in the future in these particular church communities, because they're going to have more years of funding. I was really happy with the amount of funding that they have for this community-based project. We're definitely talking about structured engagement, but what's really interesting is it's so like church by church by church dependent. The ways in which people like to get together, the infrastructure that currently is in place with small groups or larger groups. I will say what hits home for almost everybody is even just starting off a program like this with an invited speaker who comes in. And so you're sort of having a little bit of like at the church, which apparently, for a lot of our churches is something that is a normal practice that happens quite a bit. And so they talked about like, even just like an invited speaker as like a kickoff event is just hugely important. And then for me and my work in the future, I'm really interested in these like, sharing stories and church member testimonials and the ways in which you would actually use a digital health tool to be able to collect those stories and then disseminate them in ways that are helpful for the individual who's using the application. So that's something that I think is really special and interesting. For my dissertation, which just me doing this, this was about as good as I could get and graduate on time. But I definitely, I think, I was from the computer science world, and my take on all of this has just what I want to get through the computer science community is that technology cannot do it all, and that you need to, especially when working with place-based communities, create synergistic programming, because I think it's highly important. I think it's the ways in which these organizations in particular like to learn about new things and like to engage. I think an app is great for certain things, but it's not enough. It has to have complementary programming.
Are there other questions from any of the members on today's Zoom? Well, then I'm going to go ahead and ask a couple questions. First of all, like Tamara, I'm going to kind of model myself after Tamara. I've got a quick question. What was the funding source?
NSF. It was NSF for the first 4 years, so National Science Foundation. It was through their Smart and Connected Communities call. I don't know what else to call it. And it then, once COVID hit, we ended up getting NIH funding. There's also a vaccination promotion intervention within this application as well.
Which institute? Do you know?
I don't remember, not off the top of my head.
That's interesting. Yeah, I'm surprised that NIH, but there are some places within the institutes that might be interested in this.
Mm-hmm.
Well, that was my quick question.
Mm-hmm.
My larger question, one of my larger questions is, as you were presenting, I think it was a fabulous presentation. You really summarized well and gave us a clear picture of what you did. I guess I was a little confused at times because it seems like you're developing this intervention for very specific churches. So, my initial question early on in your presentation was more about what do you see as the potential generalizability? But then later on in your talk, it sounded like there is a vision of taking this to more globally, to other churches elsewhere in the country, that it wasn't going to be a Boston, selected number of churches. So I wasn't sure about kind of how do you reconcile this push for, I want it to be more tailored, I want it to include para contacts from people in my church. What do you do with that if your intention is ultimately to develop something that would have a broader application over other areas of the country?
Yeah, I mean, right now, the major focus for this project and my own focus has been Greater Boston area, a very local, community-based, regional type of work. I will say, so I'm also like really invested in community-based organizations because it's also like I was a case manager. It's just how I've always functioned. So part of this is like, I just want to create highly tailored interventions for specific locales. And that's my particular interest. I will say, there are certain things you can do tailoring wise. These were certainly tailored. It's now running, I think, in 10 different churches in the greater Boston area. My part of the study was just the 2, but my content is out there being used. It's also apparently out there being used in a virtual church. So there's a virtual church community that they're also testing this in, which is interesting to me because we've had to do a little magic in terms of creating national resources that apply for folks and withholding the highly localized resources, but that's programming magic. And so the testimonials, like just as an example, though I don't think it gets at the larger problem that you're pointing out, the testimonials you can also just deliver within specific church communities themselves. And then you can have the more generalizable testimonials be delivered to the samples where maybe there's not community-based content for those. That's how we're handling it currently. And like I said, even the agent, like when she opens up and starts talking about the app and the point of the app and is introducing this to the users, she even has like a message from their pastor that the pastors wrote, to be included. And then each church only sees the relevant messages, again, just through systematic programming. But yeah, it's a very, very tailored intervention. And
but it sounds like your group in Boston is thinking in terms of how to go bigger. And certainly it's been done, I don't know how successfully, in other places in terms of developing a program that's going to be targeting, academic institutions on IRB and tailoring it to the culture of this institution. Sometimes they get it, and sometimes they don't. In the tailoring process. That was an important thing. I also had a smaller question about in the education about meditation, yoga, those. Did you provide any instruction as part of suggesting those approaches to dealing with your depression? Was there any kind of instruction on meditation or yoga stances or whatever?
I don't know. I mean, we had meditation. So like the meditations we focused on that then we tailored from are things like body scan, mountain meditation, leaves on a stream, that kind of stuff. So it was very mindfulness based.
Yeah.
And then, I had a couple sessions where I got church members into the room and like we were just going line by line with how it was being delivered and other content that they would be wanting to hear to tailor it from there. But that's where those came from.
Yeah. Okay. Another question I had is, did you got 24 people, subjects in your study. Did you do, as part of any of the baseline data collection, did you ask about their level of spirituality or religiosity? Okay, good. What did you find out?
Yeah, so they were, let's see, I even might maybe have it. I actually don't remember off the top of my head. What did I find out? So I also had a much older population for my intervention study, which I thought was very deeply interesting. So the key informants that were involved originally, they all were, I would say I had like 180-year-old, but otherwise they all kind of were younger, the folks who were coming on a weekly basis or monthly basis to interact with us. The folks who then signed up for my study, the mean age ended up being 58, but most of my participants were over 70, with somebody who was 95. And so they ended up being pretty religious. I ended up using, I can't exactly, oh darn, it's not on the slide. I can't remember exactly which measure of religiosity I used, but it had subdimensions of subjective religiosity, organizational based religiosity, and non-organizational based religiosity. And essentially it was just like everybody was pretty darn religious.
Yeah,
Yeah, I would hope to use it to like do a sub-analysis and see, of those people where maybe there was enough of a difference between religiosity, like how did they accept the agent or not, or what did they think about that tailoring that I did? But unfortunately, everybody was just kind of extremely religious and very engaged in their churches. And these were also women. And I will say that they were largely also women who were highly like present within their church communities and really like they were leading work, different groups. So it's just kind of, it's a slice of the pie that I think is, it's important to understand the level by which they're already interacting with their communities, because that won't necessarily apply to everybody. And it would have been interesting to see how that changes things with application use.
absolutely. Any other comments or questions from anybody? All right, I'm going to ask one last question then.
Okay.
A whole bunch of questions, Teresa. We'll have to talk later on. But where is my last question? Hmm, I forgot it. It's not here on my list. All right, well, so if there are no other questions, damn, I know what it was. So you used for focus groups. And basically it started to sound like it was a little bit structured. And I would have loved to hear a little bit more about the description of those focus groups that you used in the beginning.
Yeah.
And how and whether whether you use nominal group technique, or are you familiar with nominal group technique, and how did uh, your approach was similar or different from nominal group technique?
So you'll have to tell me what nominal group technique is, because I actually
okay, fine. So that kind of answers my question right there. It's a group process where basically it's very structured. It's a group kind of session where you ask the question and they discuss it for a while. They break out into smaller groups, and then you bring them back together. You make a list, and then people vote. They have a certain amount of votes. And that's how they prioritize whatever they're doing in their, research.
It's like consensus.
That's a quick, but it's very structured.
Mhm.
And there's that voting element. My sense was you had a little bit of structure or a lot of structure to use.
It super depends on which focus group I was running, right? So I used a lot of participatory design techniques that are like these co-creation methods that we use in human-centered computing, that are very user-centric. And again, it just highly depends on which session we're talking about. But like the affinity diagramming session was run just as those are typically run, which is like they get time to brainstorm on Post-it notes, 5 or 6 ideas each. They throw them up on a wall. As a group, they discuss it without any intervention from me. And then they categorize, then they name. And again, I facilitate, but I don't guide. So that one, we also had like a community talkback session where we created a book essentially of all the takeaways for the key informants from each session they participated in. And each participant got a book. We ended up, the facilitators of the focus group left the room. They all paged through the book as a group. And then they ended up taking Post-it notes and leaving us comments about like what we got right, what we got wrong, what we need to consider. That was very unstructured in terms of like my involvement. The storyboard group, again, they see the storyboards, and then that was a structured interview guide where I'm asking questions that are pretty specific, because at that point I was less concerned about exploring and much more concerned about we need to rank some features, you know. But they ended up reviewing the storyboard, going and ranking the features independently. Then they discussed it as a group. Then they came back to me and discussed their sort of findings. That's how I ran that session as well.
All right, thank you. So it sounds like it's similar. I mean, I always feel like people are dancing around the same maypole, whether it's kind of
Discipline we're in. Yeah.
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 But at any rate, so thank you so much for a fascinating presentation, and we will talk.
Yeah.
And good to see you, Tamara.
You too. Thank you so much. I'm wondering if, Dr. O'Leary, if you can share your contact information. I didn't see it on the last slide. If you can put it in the chat, that would be super helpful.